Thank you for joining us. I'll probably go ahead and get started here in a second. Nellie wanted me to let you guys know that we are recording this. Your names will be blocked out for your own privacy, so no one can see that. But if you don't mind not asking any questions until the end when we've stopped recording, again, just so we make sure we maintain your privacy there. My name is Christina Bokat. I am not a neurologist, but I do work at the headache clinic one day a week. I am trained as an anesthesiologist and a pain doctor. And they asked me tonight to talk about what actually is a migraine. And so we'll talk about that. I was asked as well to keep it fairly short and make sure I have time to answer all your questions the best I can. So we can go ahead and get started. Basically, let's see, sorry, amazing I'm not, there we go. A lot of my patients will ask me, well, why did I get migraines? What happened? Why am I getting these migraines and why am I getting them now? We don't fully appreciate why that is. We know that certainly more women than men get migraines, about 2/3 more women. And so clearly there's some hormonal element there. There's also a genetic component. If you have migraines, you have about 50% chance that one of your blood relatives will also have migraines as well. And then migraines typically start kind of around teenage years or early 20s. That's the most common time you start getting them. In terms of what does a migraine actually look like? What are the clinical features? I think a lot of us think of the actual headache, but it seems to be more than that. There is a prodromal period, and that can actually precede the headache pain by hours to possibly even days. And you may see alterations in your sleep patterns, you might be more irritable. People may start yawning more before they get that headache. People can have even more food cravings or aversions. So I think sometimes what happens is maybe you have a craving for chocolate and you eat a lot of chocolate and then get the headache. So a lot of people think, well, maybe that was my trigger, but it could have been that headache process had already started. There's the aura for some people. Some people never have a migraine with aura, but they still definitely have migraines. And then there's the headache. Although interestingly, if you have migraine with aura, the older you get, it's possible to get the aura and never actually get the headache pain itself. But most people, at least at some point, will get that headache pain. And then even after your headache, whether it's you've taken a rescue medication and it worked, or the headache resolved on its own, or you went to sleep, whatever it is, there's often a postdromal period. So yeah, the pain's gone, but most people don't immediately snap right back to themselves. They may be listless, tired, might be irritable and not able to concentrate or go back to their work or home lives or whatever it is. So it's not just the headache, but kind of a migraine encompasses all of that. Now, to actually meet criteria for migraine, it's not actually that difficult. The way we diagnose you if you come into clinic with a migraine is from the International Headache Society, that's that IHS Migraine Classification. So usually those headaches will last anywhere from 4 to 72 hours. And then you have to have at least 2 of these following qualities. Either they're unilateral, meaning one side, they have a pulsating quality or a throbbing quality, and they're moderate to severe in pain. It's not just a mild little headache. And then also, the headache pain is typically worsened with activity. Most people, if you ask them when they have a migraine, they prefer to go lay in bed. Even if you keep on doing your daily activities, it's usually not your preference. If you could, you want to lay down on the couch, lay down in bed. You also have to have one of the following, so nausea or vomiting, or photo or phonophobia, which means light or sound sensitivity. And often people have more than just one of those, but you have to have at least one. And obviously you can't attribute it to something else that's going on. So that's how you diagnose migraine without aura. Excuse me. And then for migraine with aura, it's all the same stuff we just talked about, but people have aura sensations too. Usually it lasts about 2 to 60 minutes. And then within 60 minutes, when the aura goes away, you start having the headache itself. Now, the most common type of aura is when you have a visual aura. Normally, there'll be kind of wavy lines or sparkly lines or zigzag pattern. It starts in the outside of your vision and kind of comes across and can make it very difficult to see when you're having an aura. Sometimes you just have a blackout in your vision there as well. The second most common kind of aura isn't visual, but what we call paresthesias. It's like tingling, and it usually develops in one arm or the other, and it starts coming up your arm, usually to around your mouth. And I think this is the one, especially the first time people will have this feeling, you almost are worried you're having a stroke because it feels like your lips drooping, even though you're not actually weak, and can feel very strange. And if you have migraine with aura, that doesn't mean you'll always have an aura. Sometimes you can have the headache and not have those auras as well. So I think that kind of leads to the question of, well, what is this? What is going on in our brains and our bodies that is causing this pain? And I'm going to try to do the best job I can of breaking it down, but the honest answer is we don't entirely know what causes migraines. The original thinking was what they called the vascular theory. And that basically said that the aura symptoms were caused by vasoconstriction, or narrowing of those blood vessels. And the migraine, the headache pain, was caused by vasodilation, or expansion, those blood vessels getting bigger. That is clearly not completely the right answer. It's not that simple. What we do know is that there's a lot of large blood vessels around your brain, and surrounding those blood vessels are a lot of nerve fibers. So those nerve fibers send signals to those blood vessels in your brain. And the signals that they send are via chemicals that we call neurotransmitters. And so they release these signals for the blood vessels to expand or dilate or enlarge. And one of those signals is a chemical or neurotransmitter called calcitonin gene-related peptide, or CGRP. It's a mouthful. That's one of the neurotransmitters that's released. And that one's an important one. You may have even heard of it because that's the target for some newer injectable medications like Aimovig, Ajovy, Emgality, and they're targeting that CGRP. CGRP is kind of an interesting chemical transmitter because they've done some studies with that. And if you take a migraine patient and you start an IV in one arm or the other and you inject that CGRP, that person will get a migraine. So we know that has something to do with this migraine complex. So basically, you have those nerves, they're sending those neurotransmitters to the blood vessels near them, and they cause them to enlarge or dilate. And this causes those blood vessels to get leaky, if you want to think of it that way. That leakiness of the blood vessels causes inflammation. They actually call it sterile neurogenic inflammation, but basically it causes inflammation. And that inflammation causes the trigeminal nerves, which are the nerves that send sensation signals, pain signals from your face and your head into your brain. And so that inflammation is causing that activation of those other nerves and possibly causing some pain. Now, we don't know either, is that inflammation enough to cause the migraine on its own? We don't know. But we do know that triptan, so like sumatriptan, rizatriptan, all of those, they do seem to block that inflammation. So even though we don't have the whole picture of exactly why that migraine gets triggered or what's going on, it's important to be able to tell some of these steps along the pathway because they make for good targets for different medications. And it's possible too that not everyone's migraines are the same. And maybe one thing being a little more off balance is the cause for some people's migraines. That's why not everyone responds to the same medications there as well. I think I'll probably leave it there. Let me try to exit out of this so I can see everybody here. Let's see. Sorry, I'm not the most computer savvy here.
Would you like me to turn off the recording?
Yeah, let's turn off the recording now.